Right. Hello, everyone. I'm Ulrich Sidney, President of the Association of Future African Neurosurgeons. And today we have a journal club. Um, Before we start with the journal club, we'll have those present introduce themselves. So I'll call names based on uh, the names as I see them here. So first, Gwenole Defoe, can you please unmute your mic and present yourself?
I'm called Genolin Defoe, a food-year medical student.
Okay, nice to have you. Thank you very much for being here. So next up will be Olaoluwa.
You're welcome, doctor.
Greetings, everyone. Olaoluwa Ezekiel Dada. I'm a second-year medical student from the University of Ibadan. I'm a member of AFAN. Happy to be here.
We're happy to have you as well. So we have some other members, but they have issues with their microphone. So we'll just go ahead with the presentation. So today, the Journal Club will go through this article published in 2016 by Peter Bragg and colleagues. So the title is A State of the Science Overview of Randomized Controlled Trials Evaluating Acute Management of Moderate to Severe Traumatic Brain Injury. We'll use the same format of Journal Club we use to try and dissect this article and perhaps not only understand the rationale, but equally get some learning points so that we can ameliorate our research skills. So we'll try and keep it as interactive as possible, as always. So please feel free, if you have a question, either raise your hand or send the question in the chat or comment section. We'll make sure that we answer those questions. So you're welcome to do that. Right, so I think first things first, it is interesting to see that this is a bit of novel, I would say, kind of a study, right? Because often when we talk about reviews, we used to systematic reviews. In our group, we're all equally used to scoping reviews, and a lot of people are used to literature reviews and narrative reviews. So this here, a state of the science overview, it's a bit particular in the sense that it's a little bit closer to a scoping review because it's in the sense that it's really broad, but it concerns a field. But we get the same aspects here. We have a systematic way of searching for articles and citations, and we have a protocol that is pre-established, and we try as much as possible to map out existing literature, what they've covered, what they haven't covered, and then obviously critique what exists. So in this sense, I think this is a very good learning point for all of us. So what do we understand by a state of the science overview? In this case, the topic chosen is the acute management of moderate to severe traumatic brain injury. I think, as everyone knows here, traumatic brain injury is a very big problem worldwide because it affects so many people, especially in low and middle income countries. And we know that most cases of traumatic brain injuries are actually mild. However, what is an issue, the things that are an issue for neurosurgeons is mostly the cases of moderate traumatic brain injuries and severe traumatic brain injuries. Given that we have medical students here, some might not be familiar, but I think you've probably heard about the Glasgow Coma Scale. So we use the Glasgow Coma Scale to evaluate not only the level of consciousness, but equally to classify traumatic brain injuries. It's important here that we mention right away that by classifying traumatic brain injuries based on the Glasgow Coma Scale into mild, moderate, and severe, it's not enough because having, for example, the group of severe traumatic brain injuries or moderate traumatic brain injuries, there's so many nosological entities in that, okay? So it doesn't tell you much. It's good to have an easy conversation, but going forward, it's difficult to say much about it. What I mean by that is there's so many lesions you can have in traumatic brain injuries. You can have an acute subdural hematoma, an acute epidural hematoma. You can have contusions. You can have intraparenchymal hemorrhages, for example. And each of these diseases are actually spatial in the way that they happen, in the way that they are treated, in their prognosis. So a very easy example is the comparison between acute subdural hematoma and acute epidural hematomas. So when you compare those two entities, what you find out is that the outcomes are not necessarily the same. And this small overview that we've just done is very important because when you're going to read studies concerning traumatic brain injury, you always need to keep that in mind. And you always need to ask the question, was this taken into consideration when difference is made? Because remember, you do the research so that you can come up with a solution to a problem. And often the problem is in a clinical context. We're trying to solve a clinical problem. It can be a public health problem as well, but generally it's a clinical problem. So when we're doing this literature review, what we're trying to do is we're trying to appraise the quality of the research, trying to find out if the findings are interesting and if they should be applied in a context and specifically to our patients. So always keep that in mind. And if you keep that in mind, you'll be able to ask the right questions. So that was a brief overview about what this is going to cover. So far, are there any questions? So if there are questions, I remind you, if there are questions, please raise your hand or ask in the comment section. I will make sure we give you a chance to ask your question. Okay. Right. So what we like to do when we're I wouldn't say criticize, when we're critiquing an article is first, let's ask whether the study was relevant. Okay, whether it was whether it was important to have this study, and we use a set of criteria that are available to everyone. We call them the FINA criteria. Among the questions we need to ask is the research question novel? Is it relevant, for example? So I put this forward to you, and please feel free to answer. Would you say this study, first of all, do you think it's feasible? It was actually feasible? Do you think it is novel? Do you think it is relevant?
I think it is relevant, but I'm not really sure if it is novel. But I think it is relevant.
Okay. So why do you think it's relevant, and why don't you think it's novel?
Since one it's a review and they actually come up with many things others have worked on, and that's why I think it is actually not novel. And the reason why I think it is relevant is because traumatic brain injury, they are somehow common, and we actually need more information on this in this particular aspect too.
Yes, fair enough. I think you've argued that well. If anyone else wants to give an opinion, please feel free. I think about the novelty here, you're right, because they get information from published research. Now, one of the problems we have is that there's so much research going on, right? So a lot of work gets done, and it's difficult once you're practicing as a physician, a neurosurgeon, to keep up with this research, to keep abreast. So, like you said, it's relevant because we have a concise, cogent summary of research that is out there. In that sense, it is very relevant. It's about a very relevant topic. I would argue that there's some sense of novelty because of the way they go about the review. I would argue that they have very specific criteria. They don't just give us a review of what has been done in terms of evaluation, the evaluation of acute management of moderate and severe traumatic brain injury. They go forward and they try as much as possible to appraise the quality, the methodological quality of these studies. So in that sense, I feel I would argue. I think what you're saying is absolutely right. Some we can always argue in another sense. What is very important here, like I said, we're trying to learn, right? And this is one of the best ways for you to learn how to carry out your own research. And I would like to bring your attention to this. Look at that introduction, how it is done. So they start with an introduction. Be like really pay attention to this. Sorry, I just saw a comment in the chat box. Oh, okay. So they start with this. Here, quickly we get a sense of the magnitude of the problem. So here they use epidemiology to give us an idea. They're like, oh, moderate to severe traumatic brain injury is, it's a problem. It affects the global population. So that is the first paragraph. So that is what they're developing here. Now, in the second paragraph, what do we find? We find out that, well, although this is a big problem, we haven't evolved a lot. We haven't advanced in the field of neurotrauma. So they give us some statistics to tell us that, hey, this is a big problem, but we haven't done much. We haven't done much, and they come up with this with evidence-based traumatic brain injury guidelines. We haven't improved a lot. So they go ahead, next paragraph, and they explain what they intend to do. So they've told us this is the problem. First problem was a lot of people affected by moderate to severe traumatic brain injuries. Next problem was, hey, we find a lot of difficulties improving outcomes in this field. So if you've given a problem, then you should be able to state a solution. What do you suggest we should do about that problem? So this is what this paragraph is about. Okay, we said there is a problem. What we think we should do is this: given substantial personal, financial, and social impacts, a comprehensive state of the science overview of TBI research is warranted. And they go on, they say, why a state of the science overview? Why not a systematic review? Because that is a question someone would ask. Now, you need to remember that a systematic review is very specific, unlike a scoping review, unlike a state of the science overview. What do I mean by specific? In a systematic review, we use what we call the PICO framework, okay? P for population, I for intervention, C for comparison, O for outcomes. You can add other letters after that. You can add a T, some can add an S, but you need at least PICO. What do I mean by that? If you want to do a systematic review, you cannot do a systematic review of everything that concerns the acute management of traumatic brain injuries. What you can do is, okay, population, patients with acute traumatic brain injuries, more specifically, moderate to severe, that is defined. Intervention, you need to compare interventions. So you would say, for example, okay, pharmacologic interventions, we're going to test treatment A, and we're going to compare treatment A versus treatment B. That is the comparison in terms of intervention. So we have the interventions, we have the comparison, and what are the outcomes we're looking forward to? In traumatic brain injuries, I think you already know this, but we've said it. We're going to look at the Glasgow Coma Scale. We're going to look at the Glasgow Outcome Scale. We can look at the Glasgow Outcome Scale extended. We can look at the length of stay in hospital in the neurocritical unit. So those are the outcomes we'll be looking at, because we need something to tell us that the treatment is actually working. And what you need to keep in mind is all studies don't test the same things. You can have two studies comparing the exact treatments, but in one study, one of the outcomes is the Glasgow Outcome Scale, and in another study, the outcome is the length of stay in the hospital. So those are two different outcomes, two separate outcomes. So how would you deal with that in systematic reviews? If you ask that question, then you need to watch the first video we did about 3 or 4 months ago on the YouTube channel. Again, a reminder, if you have a question, please raise your hand or ask them in the comment section. So this is a really well-written introduction. Whenever you're writing your paper, try as much as possible to follow this, right? You introduce the problem. One of the habits we've had, I've noticed with a lot of African medical students, is we tend to define what the disease is. So now, if you're doing it for a school project, go ahead, define what traumatic brain injury is, define what moderate traumatic brain injury is, define what severe traumatic brain injury is. That is for a school project. But if you're trying to get it published, it's not necessary that you define this traumatic brain injury, because you're publishing it, with experts, so they don't need that definition of traumatic brain injuries. They don't need it no more. But if you're doing it for a school project, it's fine. In that first paragraph, you can start introducing those concepts. It shows everyone that you understand what you're doing and everything. So that is fine. So I would say generally with this first paragraph, that's what we want to do. Okay, we want to introduce the magnitude of the problem. We equally want to move from general to specific. Okay, so if you decided to go with epidemiology, one thing you can do is you can define epidemiology at the global level, and then go down to like a continental level, and then finally go down to your national level. Okay, so say I'm from Sierra Leone and I'm trying to work on a problem in Sierra Leone. I can start by saying, hey, this is what epidemiology is like globally. This is what it is like in Africa, and this is what it is like in Sierra Leone. It gives an idea. How does Sierra Leone compare with the continent? How does it compare with the rest of the world? Besides going from broad to more specific in terms of geography, you can do the same thing maybe in terms of like the disease, right? So say you decided to define traumatic brain injury. You can start by defining traumatic brain injury, then you go into the different types of traumatic brain injuries, as in mild, moderate, severe, for example. Okay, so you take a look at what this looks like, and this is what you should do. Always in the final paragraph, you want to justify why the study is important, and that is what they did here. They just justified the study. They tell us the overview, these are the aims. You want to justify the study, and you always want to give the aims. Okay, generally we tend to give just one aim, but this was a broader study, so they had multiple aims. So what would be your aim? Now this goes back to what Olaluwa said, and this is a point that is in his favor, in that when he said it's not really novel, because they said this overview updates and expands upon previous large-scale overviews published by the author team. So this has been done before. So the novelty. So again, like I said, one can argue in favor of that it's not necessarily novel. But the fact that something is not, groundbreaking doesn't mean that it's not relevant. And Olaoluwa did a good job telling us that. He told us exactly, like, this is a very important topic. So having more information is good. So you don't need to be a Nobel Prize of medicine. Your study doesn't have to be a Nobel Prize of medicine to get published. Okay, so now let's go to one of our favorite spots in research methods. Okay, let's try and understand what was done here. Let's try and dissect. Okay, I think I have a question here. Okay, so it's PICOS 2-1. It's PICOS, not PIOS. It's PICOS. Okay, so as in population, intervention, comparison, outcome, and then sometimes it's S at the end, sometimes it's T. But at the very least, you need PICO. Okay. So it's a good way for you to think. Okay, if you're going to design a systematic review tomorrow, always try to say, hey, what is the population we're trying to study? What are the interventions? How are we going to compare them? What will be our outcomes? And I think in a certain way, not just systematic reviews, but even if you're trying to develop a cross-sectional study, okay, try and think in that way. I mean, not all studies can go in that direction. Not all studies necessarily have those things, but if it's a clinical study, try and think in those terms. always, it seems easy, but you really need to be careful how you define all those elements. Let's take population, for example. If you told someone in Africa that we're studying stroke patients. Now, in some of our hospitals, we know this, in some of our hospitals, it's not easy to have CT scans, MRIs, for example. But, we still diagnose patients with stroke, right? So now the question would be, someone would ask you, hey, how do you define a stroke case? And you need to have a really good definition and stick to it. Otherwise, you introduce bias, okay? If you said, for example, I want to study epilepsy, how do you define epilepsy? Is it someone who's taking anti-epileptic drugs? Is it someone who has an EEG? What if there's no EEG? How do you define epilepsy? Okay, is it someone who has convulsions? But if you're thinking convulsions or seizures, does everyone that has epilepsy convulse or seize? Right? So you need to keep asking those questions. And one easy way to come about this is for you to read previous studies, read other studies that people have done and how they defined it. It will inform you about how you should define these elements. Now let's get back to methods. Again, this is my reminder that if you have questions, go ahead and ask them in the comment section. Okay, so let's remember what we're trying to do. What we're trying to do here is a state of the science overview, okay? We're still going the same concepts as systematic reviews and scoping reviews. So we're going to search a database that we know. We're going to search a database for specific terms, and we're going to extract articles, and we need to define how we will include and how we will exclude information. And if we think that way, so what we expect to see is that in the methods, the authors should tell us exactly what they did so that any of you, wherever you are, can do the same study. So we have a full description of the study methods in the appendix because they're full. So feel free, when you have these articles, try and take a look at the appendix. So what did they do? They were searching. So first criteria, they are looking for randomized controlled trials, not cross-sectional studies, not cohort studies, not case control studies, just randomized controlled trials. Why would they do that? Just as a reminder, remember the hierarchy of evidence? When you're thinking about the hierarchy of evidence, in terms of patient studies, the patient contact studies, randomized controlled trials sit at top, okay? They're considered a higher level of evidence than the other observational studies. And above randomized controlled trials, obviously you have systematic reviews and meta-analysis. So that would explain why they decided to go with randomized controlled trials, because they are a higher level of evidence. So they did a comprehensive, what do we know? What do you understand by comprehensive? What do you understand by systematic? Comprehensive, because you don't only search the keywords as they are, but you also search like synonyms or words that are related to them. Systematic, that means that you've described your protocol, you've done your protocol before as well, before doing the study, but you've also given a step-by-step guide, a sort of a recipe of how to come up with that study. So that's what I mean. Let's see if they actually did it. So they searched Medline and Embase, for example. They searched all these things from 2011 to 2013 using the following core terms: brain injuries, craniocerebral trauma, right? So you see here, brain injuries, craniocerebral trauma, traumatic brain injuries. These three terms would be considered, synonyms, okay? So that is why we would say, yeah, they actually, when they said it was comprehensive, yeah, that's what they meant. They looked for keywords for other things related to brain injuries, things like decompressive craniectomy, hematoma evacuation, blah, blah, blah. They have this whole list here. What did they search? Since they wanted randomized controlled trials, it only makes sense that they search a randomized controlled trial registry. And since they wanted it at the level of the world, globally, it makes sense that they went for the World Health Organization. Now, there are other randomized controlled trial registries. For example, the US has its own randomized controlled trial registry. But if you search only that registry, then you're automatically excluding RCTs from other countries, right? So that in itself doesn't really give you a comprehensive overview. It only gives you an overview from a US perspective. So that is why they felt, that's why they had to go with the WHO International Clinical RCTs Registry Platform. And these are the terms they were searching for, right? So you can take your time and go through this. I would advise anyone, if this is a study, you're like, oh my goodness, this is a great study. Take your time, read this part, the appendix. These are the things that will get you to be able to replicate the study. Very well detailed study. So let's get back here. So what did they do? They did the search, okay? They gave us the time periods of the search, and what happened? So they included full text publications from previous review that they had done before, and then they updated that search by finding new ones. They didn't do any restrictions in terms of adults or children. They took both. So again, inclusion criteria. They transferred the information into Microsoft Excel, and then they had categories. They've defined these categories. So if you're trying to do a study about this, you can use these categories because they've been described before, okay? Very interesting. Look at that. Clinical outcomes. Now, why is this interesting? Why do I say this is very interesting? Well, it means that even if you're not doing exactly like a state of the science review, if you're trying to do a study about traumatic brain injury, at the very least, you should be looking at these elements in terms of outcomes. No matter what kind of traumatic brain injury, try to look at these elements: mortality, Glasgow outcome scale, Glasgow outcome score, and the extended Glasgow outcome score. So these are the things you want to do. So that means your data collection tool should be able to get this kind of information. Very important, right? And then they had other kind of information they're collecting. I'm sure you went through that. And very important as well, they did a risk of bias assessment. Okay, so they did, like they said before, we don't just want to give you information. We want to give you information in an evidence-based medicine style. That is, okay, first, what did they do? They decided to take RCTs only. They said no observational study, first step. The next thing is, okay, it's not because it's an RCT that it's perfect. You still need to study it. Does it meet all the elements for an RCT? And one of the elements, if you remember when we've spoken about this so many times about RCTs, you need to conceal allocation, and you need to make sure that allocation is really random. So they analyzed that, and that is what they told us here. It's always important to say what the funding source did, and obviously here they say, hey, they didn't do much. So let's look at the results. Whenever you do a review that is systematic, okay, be it a systematic review, a state of the science review, or a scoping review, your first result, listen well, your first result is always this table, okay? It's always this flow diagram. In the case of scoping reviews and systematic reviews, we'll call them a prismatic flow chart, okay? So this is what it looks like. You can think, you can design it differently, but basically what we want to know is what were your data sources? You say, hey, research PubMed, how many did you find? You put there. You can add the date here. When did you search it? Okay, we searched it on so and so date. So these are the number of citations they found. Okay, then you start telling us how many of them were duplicates. You say, hey, we took out maybe 8,000 duplicates. How many of them were really relevant? And then you're like, oh, okay. And then each time tell us by why you excluded that number. So that is what it is. And next up, you want a summary table of the studies that you found. So this is what this is here, where we have a summary table of like those elementary statistics. They went through, they first of all gave us some categories, and those are the categories they're using here. So next thing is patients, population, how many were adults, how many were pediatric, what were the sizes. So here arbitrarily, from my former study, they use this definition. If you're less than 100, you're considered small. 101 to 500 patients, you're medium. More than 500, you're large. And then they divided equally by the year of publication. Risk of bias, we spoke about that in terms of random sequence. So randomization, remember, randomization enables you to, a well-done randomization enables you to eliminate what we'll call confounders, okay? We spoke about confounders before. Please watch previous videos. And if you do a good randomization, risk of bias will be very low. And then there's allocation to make sure that the researchers are not aware of which group the patients are in, so that they don't end up biasing the study. Adjustments, because of the risk of confounders, for example. They're important. So one thing that you can do to deal with them is multivariate analysis by regression, for example, or propensity matching. We've spoken about regression previously as well. So please, again, go ahead, watch those videos. I'm just going to pause here and ask the question again. Is there anything you don't understand? Is there something you need more explanation on? If there is, please raise your hand or send them in the chat. Now, so to give us this very good summary, what I want to say here, because we are all you're all early career researchers. So basically, whatever the researcher doing, right, your very first results are a summary characteristics table figure. That's what you want. So say you're studying patients in at the hospital, okay? The very first table should give us information about socio-demographic characteristics. Okay, so what we would like to know, how many people did you have? How many were male? How many were female? What were their professions? What were their age ranges? And so on and so forth. That is the first table. So avoid putting in that first table, or avoid putting things like, your outcomes already. Remember what the outcomes were, right? It was like mortality, Glasgow outcome scale, and blah, blah, blah. That's not what we want. First table, just simple information that helps us appraise the studies. And that is what they did really well here. Now, if we go ahead, now we go to the nitty-gritty stuff, outcomes for completed studies. So what were they evaluating? And straight away, what we see is a lot of heterogeneity. So they're not reporting on the same things. And in that sense, it's difficult to, appraise all of them at once. If one study is telling you about mortality at 1 month, and another study is speaking about mortality more than 1 month later, it's difficult, right? Because here, if they say, for example, mortality, 10%, that was just before the first month. What if 80% died after the first month? How do you going to compare this with the study with this one? So that is why when you're doing things like systematic reviews with meta-analysis, you equally need to appraise the heterogeneity between the studies. Very important. But equally means that when you design your own study, you should always read other studies to find out what other studies in your field report on. What do they consider to be outcomes? Try to report those outcomes. This way your study will be more useful in this sense, we'll see. Now, they came up with these tables. I hope everyone understand them. They're like 3D representations. They're very easy, okay? We have the year of publication, okay? We have the level of the risk of bias, which they already did. They gave us a summary. And then we have the trial size. Remember, less than 100, 101 to 500, more than 500. Risk of bias, we spoke about 2 levels of risk of bias. You do a risk of bias for the allocation and another one for concealment. And so basically this is a 3-dimensional where you can say, okay, so here, for example, this would mean 2000 to 2009 is the first level here. So it's small. And then if it's here, it's low bias. If it's here, it's high bias. And that's how you read it. So really interesting presentation of the information. Obviously, you have to interpret the size as well. Was the intervention superior or inferior? So that's what they're telling us. So good summary information. And then the next one here, we're thinking about what they define as robust. What do they call robust? So whenever you use a term, whenever you use anything, make sure you understand the definition. Make sure you find, and don't just define it yourself. Okay, you can obviously define it yourself, but try to find out if someone else has done it before you, because it helps. So what did they call robust, and how did they come about calling robust? They had done a previous study where they found out that whenever a TBI study, an RCT of a TBI study has less than 100 patients, well, the results weren't the best, okay? And then the next thing was it had to be at multiple centers, because when it was a single center, it wasn't really the best. So that's why they use this term. And they tell us, okay, what do we understand by robust? It has to be multi-center, it has to be low risk, and N has to be greater than 100. Which means that although they found a certain number of studies, some of them had to be excluded from the analysis because they did not meet this robust definition. Again, this is because they're using an evidence-based medicine approach to the analysis. And so you get this summary table with the author's name and the year. So whenever you're doing this kind of scoping review, systematic reviews, you will always find this kind of a table where you have the author's names and year, and then you have other information about the kinds of things about the study. Yeah. So I will stop talking for the moment, and I'll invite each and every one of you. You know, if you have a question right now, just feel free to unmute and ask a question before we go forward. I bet you have questions. So please feel free to ask questions. Right. I guess no one feels they should ask a question. No worries. Let's do this. I'll stop sharing. Now, you're going to forgive me, but I will be calling people. So those who read the article, what was your feeling so far? What you read and what you have now. What was your feeling about this study? What did you learn that was new? Were there any questions you had when you read the paper? Feel free to go ahead and speak. Anyone? Olaloa, Genole, when you read the study, what new information did you learn?
They made a literature. There's update search there, 2011 to 2015. Was it the period they used to search for literature, or or those are the articles that were published within that year, 2011 to 2015? Did you get my question?
Yes, absolutely. So what you give is the period during which you searched for articles. Okay, so what that means is, so you can search in 2020, but you need to tell us what were the date ranges. If you go on PubMed, for example, you can tell PubMed, I want articles that were published between 1990 and 2000. That is what they're giving us. So articles published within that time period. And so I invite a lot of you to go on YouTube and find videos on how to search PubMed. Why? Because as a young career researcher, one of the easiest, I'll say this, I've said this before, some of the easiest papers you can publish are, one, case reports. Now, for case reports, you need to be lucky enough to be around a patient that presents a case that is very rare, okay? And whenever you find a case that is very rare, try to publish it as a case report. Two, try to publish commentaries, editorials, letters to the editors. Those often get published a lot quicker and easily. So you as a student have greater chances of getting at that. For letters to the editor, you need to be reading articles. When you read an article and you think you have a question that's bugging your mind, you have a reaction to an article, try as much as possible to submit a letter to the editor. Okay, so read, and there's no secret. You need to read articles, and you need to be, the more you read, the more questions will come up in your mind. And if it's interesting, then the editor-in-chief will let you publish it. And then the third one is reviews, different types of reviews, be it narrative reviews, scoping reviews, state of the science reviews, but the easiest ones are the narrative reviews. Trust me, if you know how to search PubMed, you can write a lot of reviews, especially if they don't exist. So please make sure that they don't exist. The review you're trying to have, it doesn't exist. And if you can do that, then you can come up with this really, easily 3-4 papers for yourself, right? But the only way to go about that is for you to know all the literature that, all the articles that already exist in that field. So this is one of those things that you can easily get yourself published with. So you need to understand this concept.
You one time you mentioned we learning something in Cochrane. Does it have to do with literature review?
Yes. So Cochrane offers training. They usually ask for people to pay, but when you're from a low and middle income country, you don't have to pay. So Cochrane is only for systematic reviews. Systematic reviews are a little more complex, a little more time. They need more time, more resources. So I wouldn't recommend starting with a systematic review. Obviously, start the training, do the training for Cochrane, do it definitely. The full training, if I'm not mistaken, is about 13 hours of online courses with a few tests. If you do them, you get certificates. So definitely do them. But if you're starting with a review, I recommend you start with narrative reviews. That is a good place to start. Narrative reviews. So for example, say you're from like my friends here, you're from Nigeria. You can start with a review only of like research, neurosurgery research in Nigeria. That is a good review. As in, as of today, this is what it is. And I've always advised you, don't do things alone. If you do things alone, you won't go far. When you collaborate, you get a lot more. Okay, so if you're going to do something like that, invite your fellow friends who are here, because I know Darwin is from Zambia, Defo is from Cameroon, Olalowa is from Nigeria. So if each and every one of you are working on your countries and working together, then you get to know enough information about other countries and Africa in general, but you equally get to work on more projects. Okay.
Thank you so much, Dr. Horik.
You're welcome. My pleasure. Well, so Gerald, we'll just go to the next one, and please, the others, feel free to keep asking questions. So what they've done now is that they're giving us the results. In this is what you call giving the results in a narrative. So now this is a narrative of the results where they say, okay, airway, ventilation, oxygenation, 12 RCTs were found, and this is what you have 2 that are ongoing. And then they give us a summary of these 12 RCTs. This is what they found, and so on and so on and so forth. So they keep doing this till they've gone through the major. I think they had 11 major topics, and they go through all the 11. And for you as a reader, if you read this, honestly, you have a lot of information about the management of traumatic brain injuries today. And so I invite each and every one of you, if you've not read this, please read it. You will gain a lot. You know a lot about the state of science. And remember, there's no way you're going to be a prolific researcher, a good researcher, if you don't know what has already been done. If you don't do it, you will always think you have a novel idea, something that has never been done, so fantastic that is going to rock the world. And then you will work on it, and then someone will just be like, hey, this has been done, I don't know, 10, 15 times. And that was like 20, 25 years ago. So take the time to go through this. They have a special one for like ongoing RCTs. Now, here is one of the tough points usually for a lot of us researchers, the discussion. And it's one of the most important aspects. Yes, you've done the study, but you know, what you need to go further, like what are the implications of what you found, and how does this affect the future? How does this change things that we've known in the past and everything? When you're doing your discussion, your first paragraph is a sort of quick summary of what you've done. Really quick. So always discussion. Look at this, what they say here. This is the most comprehensive known overview of RCT. So you always try to say, hey, what we did is unique in its genre. If it's not unique, what is the small difference? So you could say, hey, this is one of 3 studies about this, but the difference here is this is what we did in terms of methodology, not yet the results. And then the very, very important key results. So very, very important, they found 207 RCTs, 11 intervention areas, which have been cited before. And then now, from the second paragraph, we will be discussing the results themselves, those outcomes. So that is what they do. So now what do we want? Okay, we had 11 areas of intervention. Each intervention, this is where we are right now, and you need to go forward. Okay, this is where we are. This is how it compares. Maybe we think this research should go in this direction. This is what someone else suggested and everything. One of the things I will warn you is avoid overstating your result. Avoid going way far and beyond. So you would find, for example, someone do a research in a single neurosurgery department in, say, Senegal. over a very short period and making conclusions as though they found results for the entire country of Senegal. Be careful, okay? Be careful to extrapolate, and you need to say it, okay? When you've done all those things, no research is perfect. Always have limitations, and usually those are that is your last paragraph of discussion. You need to talk about your limitations, okay? And once you've done that, you get back to the conclusion where you say the really key aspects of that study. So that is that. And what we see in this study here is they're basically telling us the same thing. Like, we haven't moved the needle a lot. We've had a lot of studies in traumatic brain injuries, but what we find out is that they've not really, in terms of their results, there's not been that many like groundbreaking, life-changing, practice-changing findings. And so what that means is, in their discussion, they need to say, hey, this is how we can improve things. And they do that. They tell us, we've seen a few ongoing studies. This is what they're trying to test. Hopefully, if we, when we're waiting for the results might change this. We think maybe if we change this in the methodology, we'll get closer. And one of them is exactly, think about the fact that they spoke about the concept of robust studies. When you read this paper, at the very least, you know that, hey, if I'm going to do an RCT for TBI, I should try to have those, robust studies elements. What does that mean? Let me try to make it multi-center. Let me try to make it so that it has at the very least 100 patients, and so on and so forth. So that is the learning point, right? That's a very important learning point. And so that should be about it for today.